Well, welcome everybody. I'll go ahead and kick us off just in the interest of time. Thanks everybody for joining us. It's Wednesday, March 6th, 2024. Special day today. We're joined by the Endocrine section, tricks and pearls in revision and non-localizing parathyroid surgery. Special thanks to Dr. Michael Singer, Henry Ford, for his help in organizing this session. Really excited to hear from our speakers and our expert discussants. So for those who have not been a part of these before, if you're not speaking, please mute if you can, just to minimize the background noise. We will be videotaping these as well, so they can be accessed later. We try and stick to 20 minutes a case, just in the interest of making sure we get through all the material. So without further ado, thank you guys so much. And Mike, take it away.
Thank you, Mike. I appreciate it, and it's a pleasure to kind of be with this group again. Tonight we're joined by an awesome group. We're going to have two kind of primary speakers or discussees. Dr. Brendan Stack and Dave Stewart, both very well known and very well accomplished endocrine surgeons with extensive, I think, interest, but obviously a ton of experience with parathyroid surgery specifically. And then we have three cases that are going to be presented. Dr. Zoe Fullerton, Dr. John Garneau, and Dr. Natalia Kyriazides. Natalia, I hope I got that right. So with that, we're going to get started. Thank you all for joining us, and obviously don't hesitate to ask questions if they come up. So Zoe, do you want to share your slides?
Absolutely. Okay, so this case is one that I was lucky enough to do with Dr. Orloff, I think midway through last year. I thought it was interesting for a couple of reasons. The central focus that we can talk about, though, is the non-localizing gland, parathyroid gland. So a 64-year-old female presented originally to most of the original part of this case was done at a different hospital, but presented to that different hospital with a primary hyperparathyroidism, which had been diagnosed after elevated calcium labs to 11.0 and a PTH of 127. At the time, she deferred surgical intervention and kind of just didn't want anything done for it. You can see just from her DEXA scan that she did actually have signs of osteoporosis, and so would have met surgical criteria for a number of reasons, but was not interested in surgery at that time. Sorry.
Just before you go on, and I know this is kind of a little bit more of the basics, but just to kind of go through this just quickly, Dave, Brendan, either of you, thoughts just in terms of indications for surgery?
Well, one thing I'll just jump in and say is hyperparathyroidism and the decision to do surgery is a laboratory diagnosis, not an imaging diagnosis. So, I mean, we could spend lots of time about talking about my imaging's better than your imaging and whatnot, but I think that's where we all need to start from. And if you look at the labs, calcium of 11, intact PTH of 127, that speaks pretty definitively of biochemical primary hyperparathyroidism.
Yeah. And Dave, looking at the numbers that you have here, and I realize there's some elements that maybe are still outstanding, but is there anything that puts this patient in the category of where you say to them, yeah, you really should be seriously considering surgery? I mean, do any of these meet the NIH criteria that everyone loves to talk about so much?
Yeah, clearly the DEXA scan and the distal radius is a little bit more classically involved with primary hyperparathyroidism, metabolic bone disease, than the hip and spine. So osteopenia at the other sites and osteoporosis at the distal radius really does suggest that the primary hyperparathyroidism is part of bone disease. I would certainly offer surgery in spite of the non-localized imaging, and I agree with Brendan, whether you do one scan or another, they do meet criteria.
Yeah. Okay,
Dr.
great.
Sorry, one more question. Dr. Stewart or Stack, Do you also obtain a 24-hour urine routinely on all of your patients as part of this biochemical workup?
No.
Yeah, I'm not sure I would be worried about that either in this case, given the osteoporosis and specifically that distal radius. Having said that, when you have non-localized imaging and mild asymptomatic primary hyperpara, that does make me want to get either the fractional excretion of calcium or the 24-hour urine calcium just to exclude the FHH. But it looks like it's affecting the bones, and FHH shouldn't really do that.
Yeah, thank you. All right, Zoe, why don't you continue?
Absolutely. Yeah. So exactly as we just kind of mentioned, she had an initial sesame scan in 2018, kind of right after her presentation, which was non-localizing. The patient was not interested in a 4D CT scan at the time, and kind of decided that she was very distrustful of healthcare kind of at baseline and wanted to do nothing about this. But eventually her symptoms did kind of get to the point where she did want surgery. So her initial procedure was done in November of 2022 without the 4D CT scan, with the laboratory values that we talked about. And as you can see, it's kind of spells out kind of what you don't want to find when you go into one of these cases. So they initially found a right-sided.
Zoe, do me a favor, because I actually think from this case and this surgical description is amazing. It's in the sense of that it really teaches you almost kind of what not to do. So do you mind? We'll go through it and we'll kind of stop along the way.
Michael, can I make one brief comment? This
Please.
reminds me of the world famous Far Side cartoon where the surgeon is throwing all these things out and says, hey, you better grab that. We may need that down the road. I mean, that's exactly what's gone on here.
Correct.
And that's a cautionary tale. But go ahead.
So, Zoe, literally, let's just kind of go through it sentence by sentence.
Yeah, absolutely. So my impression from from what they were going is they had a kind of a somewhat suspicion that there was this right-sided possible candidate. They had a pre-incision PTH of 99, so excised this right upper parathyroid candidate and did not see any drop in the PTH.
So
at that point,
sorry, continue a little bit more.
So I'm sure you were talking about, we think about our 50% normalizing value, and certainly you don't want it to get higher or stay the same. So upon that, they decided to kind of convert to a bilateral exploration, and did a bilateral lateral approach and excised what they thought was a large left upper parathyroid, and the intraoperative PTH once again stayed the same.
So let me interrupt just for a couple of minutes here. Dave, Brendan, again, just tell me, non-localizing scans, just generally, what's your approach? Like, do you say, I'm just going to go in and start on some random side, and if I find something, I'll stop and get a level? Do you say, no, it's non-localizing, therefore maybe there's more of a risk of this being foregland hyperplasia, so I'm going to definitely do a bilateral exploration? Just tell me a little bit about your kind of approach in these cases. Dave, maybe we'll start with you.
Yeah, I'll be happy to start. So Brendan taught us several years ago that the surgeons are much more sensitive at detecting the adenomas on the imaging, but maybe the radiologists are more specific. So you look really closely and you think maybe there could be something on one side or the other, because you don't want to just flip a coin. And I think if you find an obvious adenoma on the first side where you thought maybe there could be something on the imaging despite the report saying otherwise, you take it out and you check your PTH, and if it drops, it's fine to quit. In this case, it didn't happen, and the fact that it didn't drop at all pretty much confirms, especially after that second gland, this isn't hyperplasia. You're missing an adenoma here. So the first gland, I would have expected a little bit of a drop. Classically, symmetric hyperplasia, you get about a 25% drop with one gland. Maybe with two, you get 50%. You definitely don't stop at 2 if you get the 50% drop. You got to at least get 3 or 3.5. But I'd be curious about Brendan's thoughts on this.
Yeah, Brendan, how about you?
Well, so I really like how you said that, David, and thank you for giving me a tip of your hat. But yes, I am fairly image intensive. My average patient gets an office ultrasound and then a 4D CT. And when I have no localizing data and it's the first time out, I'll probably go with what my impression is and start on that side and then do an intraoperative PTH one side versus the other side with a planned bilateral exploration. I'm going to conflate just for a minute. If this was a revision case, which I think this is going to turn into, then I would get out some other imaging, what I would call bigger guns. And my favorite is the PET scan, choline based. If you're at a center that can give you C11, that's great, but most people aren't. But there is an F18 version of choline, which is, I think, a very great PET tracer for parathyroids.
So just a couple of specific points. I mean, I think, Dave, you were making the point, which is an important one, is that in patients with non-localizing studies, the vast majority of those patients still only have a single gland that's causing the problem. So I think that's an important point to just to recognize. The other thing that I just would say here that I think is important is, so they found a gland, they thought that was enlarged, they took it out, numbers don't drop. At that point, would you, either of you, Brendan or Dave, would you simply go and find another gland and take it out and then get a level? Or at the point where that number doesn't drop, do you say, you know what, I really should be looking for all of these glands before I kind of start testing PTH levels again? Brendan?
Well, I personally would, if I'm not satisfied after seeing two glands on one side, I would check a level and then go to the other side. I wouldn't do a level after each putative gland that I uncover because I think that gets confusing. It's very time intensive, and I just don't find that to be helpful.
Dave, let me ask you a question. So, and I know that this is not the case. So you have a patient with non-localizing information. What is your approach to four-gland hyperplasia? So you go and you find the glands. How do you approach it? I mean, do you find glands and take them out sequentially, or what's your technique?
Yeah, so presumably we're talking sporadic, not hereditary, right? Because
Correct.
hereditary, you're doing a bilateral exploration, even if the imaging's localizing. So
Correct.
it's sporadic. I
Sporadic.
feel like when the imaging's non-localizing and it's sporadic, it's about 50-50 hyperplasia versus small adenoma somewhere. One of the comments in the chat was, do you start with the IJ sampling low at the beginning of the case? I think that's a pretty reasonable option, particularly, in the case when you're struggling and you're missing glands on both sides. It can be very helpful. If it's substantially different, I do like to just stick to the side where, if it's 500 and 100, I'd only look on the 500 side. I don't believe that a 10% difference is a convincing difference. I think the literature kind of suggests that. I mean, to me, it has to be a substantial difference to make me think I only need to be on one side. But no, I would typically, unless I thought that I had seen the adenoma on the imaging and went right to it, the first gland, I wouldn't be taking glands out. I would go and clip them and continue on and try to find all four. It does get confusing if you find three sort of normal glands and you can't find the fourth. Could it be hyperplasia? Then you could get away with three. I mean, it's easy to sit here on the panel and say, no, you shouldn't do that. But if you take them out, just don't pass them all off to pathology. Make sure you save some. The cryopreservation concept here, I think, is one option, but you could also just send a piece of the parathyroid to see if it is parathyroid and save some that you could auto-transplant. Just don't give them all away in case, you've taken basically the three normal glands and you still haven't found the adenoma, which in this case, at least they didn't do that. I think they stopped after the two didn't fix it. So in retrospect, probably should have left those alone, but it's easy to say that in retrospect, I think.
Yeah,
So I think the scenario that Dave just gave, as far as finding 3 glands that are perhaps normal and taking them out and then sort of crossing over that bridge of passing off the specimen, I have seen a couple litigations over that where the adenoma was left undiscovered, and then the patient then had the requirement for revision parathyroid surgery and was left hypoparathyroid, which another mantra I always beat into my residents: there's one thing worse than hyperparathyroidism, that's hypoparathyroidism. So we always need to be concerned about that.
Yeah, and I think what's important to recognize is that a lot of times you don't recognize or realize that a gland is normal or abnormal until you've compared it to the other glands in the neck, right? Sometimes you see a gland and you convince yourself, oh, that looks enlarged, and then you see another gland, and you're like, oh, that other one is totally normal. So just in the interest of time, so Zoe, why don't you continue? I know that they then found what they thought was a normal inferior gland on one side, looked on the other side, biopsied a bunch of things. So why don't we go just to what they found in terms of the biopsy, because this is where like the story switches, and I want to make sure that you get through the rest of your presentation. Zoe.
Sorry.
Oh, go ahead.
Absolutely. So yeah, they kind of continued their search. So they excised the right upper pole. They looked for a right lower gland and did not find one. So they actually excised, performed a cervical thymectomy. And then on the left side, they found a left lower and marked it, as we were talking about, did not take it out, kind of chose to preserve it. They found a left-sided retroesophageal nodule, so looking in the retroesophageal space, and excised that. And then at the end of all this, unfortunately, the PTH remained elevated essentially at preoperative levels.
So why don't you just go ahead with the presentation from here?
Yeah, absolutely. So this is the final surgical pathology. So you can see that there's 2 parathyroids in the specimens, and then the rest of them were fibroadipose tissue or just thyroid tissue. Unfortunately, this patient went on to develop a post-op hematoma requiring evacuation and ICU admission. So I think that just kind of speaks to, the risk of the unfortunateness of kind of proceeding with this extensive amount of dissection and not getting it, and kind of the patient's frustration with that.
Zoe, does your pathology department weigh your parathyroids?
Ours, I believe, does, because Dr. Orloff always wants to record the weight. This was not done.
I think that's very important. That's why I brought it up. 35 to 50 milligrams would be normal by weight. So I think that's something that sometimes you may have to hang your hat on. Go ahead. I'm sorry.
Oh, that's great. So this patient, Dr. Sack actually predicted the end of this case, got frustrated and went to Greece and self-paid for an F18 choline PET scan because she wasn't able to get it in the United States, which was
she
incredible.
She didn't look in the right place. You can get them in the US.
Well, I think she just got tired of waiting.
Yeah.
And just decided that was going to be. And as you can see, it actually localized pretty incredibly. There's a right lower adenoma that you can see kind of in these 3 cross-sectional images appearing. While we don't know, and then presented to our clinic, at which point in-office ultrasound kind of corroborated this with a right lower level 6 region candidate at the site of retention. At that point, you can see she was still frankly hyperparathyroid, the PTH of 147 and a calcium of 10.6. And then underwent a surgical procedure where you can see that based on the localization that we were given by the PET scan, we were able to very quickly identify this adenoma and dissect it out. And then pre-excision PTH was 115, and 10-minute post-excision was 30.1 with a aspirate of greater than 5,000. And so she's now doing very well.
Great, thank you. And Zoe, your talk leads right into our next talk. So thank you. We appreciate it. My understanding, are you doing a head and neck fellowship next year?
I am.
Oh, good. So you'll
Yeah.
get many more opportunities to attend this tumor board.
Yes.
So thank you, and we're going to get John's slides up if we can. So if you could stop sharing.
Okay, let me see if I can get.
So Zoe's case kind of ended up with a reoperation, and that's what John's case is going to be on. And so we're going to use this as an opportunity to talk a little bit more about kind of the needs going into reoperation, or at least the considerations, and then we'll use this time also to just talk a little bit, I think, about technique, if that's okay. So John, why don't you kind of start us off?
So everyone can see. I'm assuming, right? Looks okay.
Great.
All right. So yeah, this dovetails really well into our case here. So the case is a 60-year-old female who came to us after having a history of a right-sided parathyroidectomy performed several years ago. And you know, the unfortunate thing with her case is that basically after the surgery, she still reported persistent symptoms of hypercalcemia, so mental fogginess, bone pain, abdominal pain, and then routine blood work still had hypercalcemia. I had access to the DEXA scan that showed progressive osteoporosis. I didn't have Z-scores or numbers to report, but this was her blood work when she came to us after this parathyroidectomy several years ago. So her calcium and PTH, as Dr. Stack, said, is indicative of a primary hyperparathyroidism. Her TSH was normal, vitamin D normal, urine calcium, which was obtained, was normal just because it's potential revision case. So what we really aim, what we really stress in the revision setting is to get as much information of what you had or what was done before. So whether that's access to your surgical pathology, any imaging done, any reports, even a discussion with the surgeon if you have that ability, to really get a sense of how much dissection was done. I mean, this was a little bit different than the case that Zoe presented because this was a very limited dissection. But what was interesting is that the surgical pathology, what was labeled as right inferior parathyroid tissue in 2 separate specimens from the outside surgery, was reported as a lymph node with non-necrotizing granulomas, and actually no parathyroid tissue was identified at all in both what was labeled as parathyroid tissue in 2 specimens. And actually, furthermore, the operative report, which we had access to, I kind of paraphrased a little bit, but the salient points mentioned was that the surgeon had mentioned that they encountered some dark necrotic appearing lymph nodes, which were biopsied and sent for pathology. And this was actually sent for frozen at the time. And the necrotic appearing lymph nodes that were possible parathyroid glands returned as granulomatous disease consistent with potential sarcoidosis. And then this was in the op report, which would explain hypercalcemia. So essentially, in the operative report, dissection and any further procedure was halted in the thought that, well, the hypercalcemia was sarcoid, and actually we just encountered some central compartment lymph nodes that were sarcoid. Don't have to do a parathyroid anymore. Things stopped. Unfortunately, we didn't have access to any intraoperative PTH levels. I assume they weren't drawn. And then no prior imaging studies were able to be reviewed. So I actually have a video. So we chose to do 4D CT and ultrasound. My preference is to get those 2 modalities together to see if one can corroborate the other. I've had issues where an ultrasound detects something very obvious and a 4D CT misses it, and vice versa. So that was kind of the reflexive thing to do in this case, to get the appropriate localizing imaging for what the standard would be for myself. And this is a video, and I have the 2 phases that are most important. So this is the first non-contrasted phase for this patient. And, as you scroll down, we're looking on the right side and you immediately see surgical clips. So this was in the paratracheal dissection space, right along the thyroid tissue, and then the non-con, just for the fellow purposes and what we're looking at, things that are hypodense to the thyroid gland are typically indicative of parathyroid adenoma or parathyroid abnormality. So the non-con phase, you're looking for, density difference from the native thyroid tissue. And so in this case, there was a hypodense lesion basically right next to some surgical clips. So right here is a good point point in the video where there's just basically a hypodense lesion in the right thyroid pole right beneath a surgical clip. So then later on in the arterial phase, so that's, circling that area there. And again, there wasn't really, just to, not to just halt the search at this point, there wasn't anything, obvious in, the contralateral side or down in the anterior mediastinum or any of these typical ectopic spaces, the retropharyngeal space or even a high up in level 2, there was nothing indicative there. And then in the arterial phase, which plays next, there was arterial enhancement to that same area. So again, surgical clips in the area where the suspected parathyroid tissue / lymph nodes were removed. And then there's this arterial enhancement that was called, and you can kind of see this kind of peripheral vascularity around that area. And then what's nice is that this correlates very well to the ultrasound that was done. And I have still images of that area. The suspected target you can see here is almost this intrathyroidal or inferior thyroid nodular looking lesion, but again suggestive of a parathyroid abnormality there, just based on the 4D CT and obviously blood work.
John, I'm just gonna have you hold on for a second there. So a couple of years ago, and Brendan can tell you the exact year, the endocrine section under Brendan's guidance published a paper on reoperative surgery. And I really encourage, for any of you who are going to encounter these cases now or in the future, it's a really good kind of guidebook for approaching these cases, how best to do it, and so on and so forth. I think, John, what you said about gathering as much information as possible is absolutely essential. I will say, and this goes back to Zoe's case, that it's actually one of the reasons why in the first case I noticed that they didn't biopsy. When they said they saw, I think, the left inferior gland and they marked it with a clip, they didn't biopsy it. Well, as a surgeon, if I'm going to have to go back into that neck, if they haven't proven it with pathology, basically they haven't proven anything. It's really kind of critical. I have a question though for Brendan to start with. Brendan, so John showed us some really nice localizing information. Is that obligatory in reoperative cases? Can this be approached the way you would approach a primary case, where it's like, it's non-localizing, I'll just do a bilateral neck exploration? Tell me about the value or need for imaging in these cases.
Well, in the guidelines that you referred to that we produced, I believe it was in 2017, we had a consensus among the authors of the paper, and we had a high level of consensus for, in the setting of reoperative parathyroid surgery, localizing data is very, very important. So whereas some people can be a little more casual about, it didn't localize, I'm going to do a bilateral exploration anyway, I'll take care of it. And in a high volume operator, that attitude I think is appropriate and usually justified. Even high volume operators felt that it was necessary to localize in a reoperative setting. After you do the first couple of steps, which would be repeat laboratories, exclusion of diseases which can mimic these things, confirmation that you're dealing with primary hyperparathyroidism.
Dave, any comments you want to add to Brendan's? We'll get in a minute, I think, into some of the maybe techniques, but just in terms of the way you even think about these patients, is there things that are absolute no-goes? Are there things that you say, I don't need that information?
So I guess a couple of comments. First, on the sarcoidosis, it doesn't cause hyperparathyroidism. So if you had a patient that was hypercalcemic and the PTH was normal and you found sarcoid, maybe you bail out at that point, but otherwise they should have kept going. But thankfully they didn't. And so I agree with Brendan, you would always get repeat imaging before revision parathyroidectomy. But if you think that the patient had hyperplasia and they only went into one quadrant and took one gland, and it was hyperplastic, enlarged, hypercellular, and the PTH went down a little bit, but not enough, I think it is okay to go do a bilateral exploration. But if they've done the entire thing and it was a 6-hour operation, that's not going to be an easy just go back in and fix it. So I think you have to consider the extent of the original surgery. In this particular case, I would probably stick a needle in that. I think that it's compelling that that's likely, the adenoma, but it's such an easy biopsy, and really you're doing it for the PTH and the aspirate level. I would always send it for cytology. But for a primary case where I suspected an intrathyroidal parathyroid, I'd probably be just as happy to go in and take it out and see. And if it's not, then I just do the bilateral exploration. But for a revision case, I'd be more likely to needle biopsy that suspected intrathyroidal parathyroid.
And the other thing I would just add to your comments is I think that this case really illustrates how being able to read your own ultrasounds or understand someone else's ultrasounds is absolutely critical. Part of, when you see an ultrasound report or a sestamibi scan, it's like, yeah, okay, it's a right inferior gland. But if you actually know what you're looking at on this ultrasound, it's not just simply that it tells you, okay, yeah, it's an inferior gland, but it really directs you very clearly so that when you look at this case, even before you kind of start, okay, if I'm not careful with my retractor, I'm going to be beyond this and retracting this up with the thyroid before I even kind of think about it. So John, maybe you can just continue from there.
Yeah. That's a great point about the FNA with the PTH washout. I will add it as because you brought it up, Dave. I've actually been bailed out. I was doing a parathyroidectomy in a radiated field for oropharynx cancer, and who had a patient who had a thyroid nodule that was a Bethesda 3 lesion. So I did a ThyroSeq to kind of determine if I needed to address that nodule at the time of the parathyroidectomy, and the ThyroSeq came back identifying the nodule as parathyroid tissue. And it was actually a non-localizing study. So then I just went and did the thyroid lobe, and that was good. So I've actually even used the ThyroSeq sometimes to tell you, because the pathology telling is typically a Bethesda 3 lesion. And if you don't do the PTH watchout, you may just have an indeterminate nodule. So that's
I definitely seen that scenario. I think if you don't know the patient has primary hyperparathyroidism, that's a pretty reasonable way to go. But if you know before you stick the needle in that the patient has primary hyperpara, it's a $50 PTH test versus a couple $1,000s for the molecular. So, and your point is well taken. The cytology will often not be able to call parathyroid. It'll often look like a possible follicular neoplasm.
I would just caution because I remember a few years ago it became in vogue for many of the endocrinologists to do FNAs of presumed parathyroid adenomas, and that became like kind of routine, and they thought they were being helpful, and it really was not helpful because those cases, the surgeries became, at least in my practice, much more challenging just technically because of that. So I think in a reoperative setting like this, I think it is an excellent idea, but I just want to make sure that people don't start to say to do that on a routine basis in primary cases. So John,
no, I agree. Particularly, it's helpful in an intrathyroidal suspected one. I mean, I think that's where the value. And yeah.
So John,
so with this information, with the localizing studies being suggestive of a parathyroid abnormality, and then the blood work being indicative of still having primary hyperparathyroidism. We went to the OR, and basically because this was the target, a couple points to highlight. A slightly larger incision that was done in the beginning, just to kind of get access to potentially undissected fields and tissue planes. But basically here, what you're looking at is going right at the right side, right where the imaging localizes. And I will mention, we at our institution do all intraoperative ultrasounds before anything. So you have a good target with the patient on the table. And then in this area where the forceps are pointing to is sort of the inferior thyroid region, right beneath the surgical clips, there was, the suspected area from the imaging, and basically with just a small thyroidotomy, there's a parathyroid adenoma. kind of sitting right underneath surgical clips. Kind of unfortunate that basically those lymph nodes thought to be suspected sarcoidosis were basically removed from just the central compartment right in that area. So it was basically like a cell layer off, but because the prior surgeons had not gone and actually done any sort of thyroidotomy, the area wasn't able to be removed. So just by doing that little thyroidotomy, taking just a small cup of thyroid tissue, you can see parathyroid lesion comes out. Sent it for frozen to confirm it actually was hypercellular at the time. Again, to the point of you're in a reoperative field, doing still a targeted minimally invasive approach through the original path of dissection. So you want to make sure that you don't have the satisfaction of finding something and then losing the ability to potentially do a foregone exploration at that time. So intraoperative PTHs were confirmatory. It started at 52 pre-op, and then baseline was 94 at excision, and then 21 down to 18. And then the weight of this lesion on final pathology was 0.57 grams. And so all of that taken together, bilateral exploration was not undertaken, but we felt this was pretty successful treatment, and just kind of unfortunate that the plane of dissection from the outside surgeon was pretty much in the right area. Just these other nuances weren't appreciated.
Thanks, John. So,
yeah.
Brendan,
quick comment. If you have a fair amount of revision cases in your practice, you will see that phenomena happen many times where it was close but no cigar, and they were just a few cell layers away from finding this, especially if you have like a low-lying superior. I've seen this happen many, many times. Sorry, go ahead, Michael.
Yeah, no, I was going to ask you, Brendan, is just kind of what do you think are the things, if you could say principle wise, that kind of lead to the most missed adenomas? Is it that people just don't know what they're looking at? Are they not going deep enough? Like, if there are a couple of hints you could say to people, hey, these are the things you should make sure you're doing to find these glands.
Well,
I'm talking about the primary.
I'll invoke the name of your former fellowship director, fat, looking for a cluster of fat, looking for the typical mahogany, or as I would describe to my residents, it looks like a piece of liver in the neck, the appearance, looking for a pedicle. These are all little clues that can help you when you're in the middle of the fight and you're looking at the operative field.
Yeah. I think making sure you're deep enough, finding the nerve could sometimes be helpful. All of those.
Very helpful.
Yeah. Dave, let me ask you a question. So in this case, it seems like John, and I'm not trying to demean your surgical skills, John, but it seems like you kind of got lucky in the sense that you didn't have to deal with what you sometimes have to deal with in these cases where there's really extensive scar tissue present. So Dave, any suggestions, approaches, techniques that you use to kind of deal with that in reoperative cases?
Yeah, I think that we heard on the first case a lateral approach, which didn't make a lot of sense to me, especially when they were going with a bilateral lateral approach when they missed on the first. But in this case, that would be an option. I think sometimes I'll try to go through the central, separate the strap muscles. If it's not too scarred and you're looking for an inferior gland, that's the easiest way to get there. But if it is very scarred and the straps are, especially that sternothyroid is scarred to the thyroid, as you start to peel it up, it can cause bleeding. So you can either go between the two strap layers and retract the sternohyoid laterally and the thyroid with the sternothyroid medially, or bring both strap muscles medially and come in laterally. That can sometimes be a good approach. It's particularly helpful for missed superior glands. And I would say with today's CT fusions and 4D CTs, that we don't have as many of those called an inferior adenoma when it's really an inferiorly migrated superior that people miss, but it's still probably the most commonly missed adenoma. So if that's the case, that they went into the traditional inferior quadrant, scarred it up, but they just didn't get deep enough, going laterally, I think is an easy option. I do think that if you get low near the sternal notch, The strap muscles are much farther from the trachea, and it's a lot easier to get into that versus closer up near like the cricoid, everything kind of scars right down. In this particular case, John, I'm assuming the calcium went back to normal because some people have sarcoid and primary hyperpara.
Yeah, I didn't include on the slide, but the calcium actually went to normal range.
Yeah,
Post-op, we
so,
checked. Yeah.
Dr. Stewart, in your hands, when would you consider radio-guided surgery in the reoperative setting?
That is a good question. So I find it helpful when the thyroid is gone, or if the parathyroid has been transplanted into some muscle, and particularly the secondary hyperpara, where you may need to go get more of the tissue, but it's hard to tell exactly how much because it's not going to be a single gland. It's going to be muscle with parathyroid tissue, and so if the sestamibi is positive, you can sort of take out tissue till the Geiger count or gamma probe no longer, is showing any, and then put a little back in. So for MEN1 patients that have had transplants or secondary hyperpara, I found that very helpful. When the thyroid is still there, like this case, I don't think it would be helpful at all, in my experience.
So, John, I'm going to ask you to thank you for the case. I'm going to ask you to stop sharing so we can move on to Natalia's case. The other thing I would add, Tanya, to that question is I do think that going forward, things like autofluorescence or fluorescence imaging are going to probably have a big impact on our ability to kind of recognize glands, both in primary cases but also reoperative cases. Brendan, I know you have a lot of experience with radio guided surgery. Do you have any additional comments to Tanya's question?
Well, the one thing I would say is I'm a big fan and used it for a couple decades, but it's not something that if you're a casual user or have no experience that you can, if you're in the middle of a tough case, it's not something you can whip off the shelf and expect you're going to get magical results. These are not divining rods. They have to be used with skill. They have to be used with understanding of the physiology, or in this case, the pathophysiology.
Yeah, thank you. Thank you, Brendan. All right, so in the interest of time, we're going to move on to our last case, which is really kind of distinct, which is that we're going to be talking about secondary or renal hyperparathyroidism. So, Natalia, thank you for joining us. If you want to just get started with your case, that'd be great.
So the case is a 63-year-old female who, with stage 4 CKD, currently not on dialysis, with refractory secondary hyperparathyroidism, who was referred by the endocrinology team. She was on the waiting list for a renal transplant, or in the process of becoming on the transplant list due to her progressive decline in kidney function. And the recommendation was for treatment of her hyperparathyroidism prior to transplantation. Her past medical history includes hypertension, osteoporosis, and her CKD was induced by long-term NSAID use. Listed are her medications. When we saw her in clinic, she otherwise had a normal exam, normal cord motion. Her labs at presentation were notable for an elevated calcium of 11.3 and PTH in the thousands. For preoperative.
Thank you. Natalia, you have I don't know if you know, you have a whole fan club on the Tumor board today.
I saw that.
So, Brendan, I'll just start with you on this question. These patients, and this is true certainly for pre-transplant, post-transplant, these are distinctly different than primary hyperparathyroidism patients. Just in terms of the way kind of you think about approaching these patients in terms of imaging, because these patients by definition have all glands. And when I say all glands, I say that because they can also have supernumerary glands, but all gland involvement. So what do you do in terms of imaging in these patients?
So that's a great question. I mean, I think there are at least two schools of thought that I can identify for this group. One is they're going to get a bilateral exploration, so why bother with the imaging? Well, I guess I'm a bit of a imaging nudnik in that I like to have images. I like to have images in the OR that I can refer to. And I think every patient is different. So my personal thing is, if I'm not going to cause kidney damage that is going to complicate this situation. So in other words, if their kidneys have given up the ghost and they're not going to be prone to any insult from contrast, my preference would be to get a 4D CT. So I have an intraoperative map of where I need to go, what I should expect to find as far as size, up, down, right, left. But if people are sort of on the fence as to whether they're going to get a transplant, they still have a functioning kidney, albeit compromised, then you wouldn't want to use any imaging in those cases that would put a contrast load on the kidneys and potentially knock out some nephrons.
Okay, great. Thank you. All right. So Natalia, so why don't you carry
Michael,
on?
can I ask a
Yeah,
question?
please.
So that hypercalcemia begs the question of which comes first. So I just want to go back in the patient's record and see if the hypercalcemia preceded the chronic renal disease. I would think this is primary hyperpara, and it would change my paradigm quite a bit. Now, the PTH of 1,000 does kind of suggest it, and so this may be one of those secondary turn tertiary cases, and I would certainly believe that is a possibility, but particularly in somebody who is not on dialysis yet, I would want to make sure that I went back and looked at those levels. So do we have any of that, Natalia?
Yeah, so she was a normal calcemic initially, and over time, as her kidney function declined, became hypercalcemic.
Dave, I think it's a really excellent point, which is, and this was one of the things that my mentor Dave Terrace has taught me, which is that just because you are a dialysis patient, for example, doesn't mean you can't have primary hyperparathyroidism that's caused, in fact, by a single gland. But I think for the sake of this conversation, we're gonna go ahead with the more kind of standard secondary
Multi-gland premise, yeah.
Yes, that's okay. But I think your point is a very good one. It's not just because you have kidney disease you can't develop primary disease. By the way, that's pre or post transplant. So, Natalia, please.
And so pre-op for imaging, ultrasound was obtained, and there was a 17 millimeter potential candidate just posterior inferior to the right thyroid lower pole. That you can see here, and there's peripheral vascularity on color Doppler ultrasound. There was also a potential second candidate, 10 millimeter on the left side, just posterior lateral to the left thyroid lobe at the upper pole. And because of her kidney function, we weren't able to get the 4D CT scan. And so a CT neck without contrast was done, and, hard to fully assess, but what we thought we saw was the right-sided candidate, just inferior and posterior to the right lobe, which coincided with the ultrasound. And then on the left side, potentially that area, the 10 millimeter target that was seen on ultrasound, just posterior lateral to the left upper pole. And so I'll keep going. So the operative plan, so preoperatively, there was a discussion with the nephrologist to establish the extent of surgery and what the PTH post-op goal would be. Given that, she's an anticipated renal transplantation patient, we wanted to leave her enough parathyroid reserve. So the goal was established at less than 300. And so the plan going in was for a bilateral parathyroid gland exploration with a subtotal 3 gland excision, leaving a gland behind.
So, Natalia, I'm just going to have you hold off for a second, because I think there's a ton of really important points to be made from this slide. So, I'll have you start, Dave. Just in terms of target, that these patients are obviously PTH wise, this is a completely different situation than primary patients. So does this goal kind of fit with what you're looking for? And what happens if you achieve a goal, I mean, are we looking for a number of 20 like we're looking in primary hyperparathyroidism, for example?
Well, this reminds me of some advice I got from some more senior surgical colleagues, renal transplant surgeons, that said, if the patient is not on dialysis, do not make them hypoparathyroid. That will be a real disaster. So I don't think you're as aggressive in this patient as you might be in somebody that is end stage on dialysis, never going to be transplanted. I actually think the goal for this surgery should be to get the calcium normalized, because if you're going to transplant them and they're still hypercalcemic, that's not going to work. So while I agree that we don't want their PTH to be too low, I would certainly feel like I failed if the calcium remained high.
So let me interrupt you for a second. So surgically, and Brendan, I'm going to ask you this question in a second. Surgically, Dave, in this patient, what is your kind of surgical approach?
So I think it's a 4-gland exploration, and it's either going to be a 3 or a 3.5 gland excision, depending upon how the glands look. If you've got a relatively normal appearing gland and 3 abnormal glands, I definitely would just take 3. If they're all 4 grossly abnormal, I'd probably take part of that 4th gland. I wouldn't take the first 3 and then try to take that portion of the 4th gland. I'd take the portion of the 4th gland first and make sure that I thought I had some viable bleeding parathyroid tissue there. And I agree, the PTH, I would probably have guessed that I'd wanted the PTH to be more like 100, but the point is, don't make them hypopara.
Yep. Brendan, in terms of choosing, and Natalia, maybe you could just go ahead to the next slide, because I think the pictures are on there and I think it's valuable to see those. Is Brendan,
Beautiful.
in terms of choosing kind of what to leave behind, or which gland to leave behind, or what part of a parathyroid gland to leave behind, do you have any suggestions for people?
Well, my suggestion is, if you have multi-gland disease, find all the glands and leave them in situ and vascularized until all are exposed and all can be evaluated. And then what I like to do is either, as David had explained, a 3 or a 3.5, probably more frequently a 3.5. And I do the half gland on the most normal of the 4, assuming we're not dealing with supernumerary cases, parathyroid gland, and make sure that there's good vascular appearance, that the vasculature is intact, because sometimes with these large lesions, you can sort of get coiling of the polar vessels and stuff like this. So you want to make sure that the remnant that you leave behind isn't going to become venous congested and infarcted. One other thing I want to say to Natalia, and this perhaps may be one of the most important things projected all tonight, is your 2x2 table. 2x2 tables are excellent. I think they're excellent both in primary surgery and certainly in revision surgery. And we present the 2x2 table concept in the, among other things, in the revision guidelines.
Natalia, sorry. I think this is actually an important part. You have in this 2x2 table, as Brendan just talked about, you have this comment about nodular. What does that mean anything to Brendan, Dave? Does that mean anything in particular, like nodular parathyroid versus non-nodular parathyroid?
Well, I definitely like the term nodular hyperplasia as a good description grossly for what renal failure parathyroid glands look like. And, the nodular, it has a density that is often stiffer and closer to thyroid than a typical parathyroid adenoma in a primary hyperpara case. And different than, I think, hyperplasia in a primary hyperpara case. So they're clearly abnormal, and those are the ones you'd want to take out. I think sometimes it is hard to tell if they're thyroid or parathyroid in those cases. And this one shows 2 very close together. And the other thing that I think can be hard on the imaging and even intraoperatively is it one gland, or those 2 glands that are sort of just pushed together because they're so big?
Yeah, I think that's an excellent point, and I think your comment about how the abnormal glands in these cases is very different than the way they look abnormally in primary cases. And a lot of times, I think people can you can easily overlook hyperplastic, say renal related parathyroid glands because they can look like just part of the thyroid gland. I'll say that for myself, that when I'm trying to leave behind a remnant, I try and avoid leaving behind nodular remnants of these glands, and try and leave behind something that at least looks a little bit more like say foregland hyperplasia type glands, where it looks just more like an enlarged normal parathyroid gland. I think that that once it becomes nodular like that, I think that represents such abnormal tissue that, say, for example, the chances of them going on and having persistent hyperparathyroidism even after a transplant, I think is probably just higher. And there's some data to suggest that's true. So Natalia, do you want to just finish up your presentation?
Yeah, so in the OR, we first started on the right side because the larger of the identified candidates were on that side. They identified all 4 before, making a decision there. And so on final path, it did in fact, our decision intraop was concordant with our decision intraoperatively. And so all 3 glands that were removed were in fact enlarged and hypercellular with nodular hyperplastic change. And the PTH pre-op before incision was 1343, and it came down to 252 after surgery. The calcium also did normalize. I don't have it written here, but it was 9.7.
So first of all, thank you. I'm going to have David, sounds like you have a comment, and then I'm going to have one last question, then we're going to wrap things up. Please, Dave.
So these patients, they need to stay overnight because they can really drop their calciums. And so it's different than the primary hyperpara patients, which we can almost always send home. So that's one comment. And then the other is I find that the kinetics are much slower in these renal failure patients. So I like to get another PTH on post-op day 1, and it can drop substantially. Typically, for a primary hyperpara patient, it's going to be at the nadir by the PACU, but not for the renal failure patients.
Yeah, I agree. I have a similar experience. Brendan or Dave or both, historically, people have talked routinely about doing thymectomies in these patients. What is your approach, thoughts about thymectomy? Is it always needed? Is it sometimes needed? Brendan.
If I'm having trouble finding it, I certainly have no compunction about taking out thymus either on one side or both sides. But if the disease is obvious to me and I'm able to take it out, if I get otherwise the surgery goes the way that I would expect it to go, no, I do not routinely take out the thymus in these cases.
Dave?
I would agree with Brendan. I think that sometimes you feel like you need to, but you don't routinely. I would say MEN1, though, I always do. I think those patients have a high, persistent recurrent rate.
Yeah. Different population, but I agree with that too.
Yeah, I mean, just so people are aware that the thymectomy idea is that theoretically these patients, these renal patients, because of the intense drive to make PTH, they have a higher rate theoretically of supernumerary glands. So that's kind of the idea of doing the thymectomy. But I think it's important just to hear to, again, very experienced parathyroid surgeons who say they do not routinely do that. And I would add that I don't routinely do that either. So with that, I'm going to wrap up. I really want to thank everyone who joined, who presented. I know that everyone's really busy, and so to take out time, it's really just shows your kind of commitment to the education of the fellows. So thank you.
Yeah, and
Bye.
I'd like to echo that real quick before everybody steps off. I mean, we put these on once a month, and this has been one of the best sessions as far as pearls and tricks and things. A couple of us were chatting offline in the box about this, and I can't thank you guys enough for taking the time. We know everybody is swamped with obligations. You know, I know the fellows, not only those here, but also those who will go back and really get a chance to spend time soaking this in from the recorded sessions. Really, really appreciate it. Thanks, Natalia, Zoe. I know she had to step off. John, great cases. Brendan, David, thanks for your expertise. Michael, thanks for organizing. We've had a couple of other guest members, Tanya Fancy, Tony S. Kander. I know Amy Chen and Greg Randolph and Don Wade were on here as well. So thank you guys all so much. Our fellows are lucky to have you. So next month, April 3rd, is going to be TORS or radiotherapy or pharyngeal cancer dilemmas. So thanks, guys. Have a great night.
Thank you, Mike. Have a great night, everyone.
Thank you.
Everyone.